Hello everyone and welcome to CT Anatomy. My name is Clark and I will be taking you through heart today. So a little introduction. You definitely want to understand the basic blood flow direction of the heart. So if you've never had this in a course before in undergrad, then here we go. So you have 4 chambers of your heart. You're going to have your 2 atrium and your 2 ventricles. So those are your 4 main chambers of your heart. Then you have 2 great vessels, your pulmonary artery, which goes and takes deoxygenated blood to your lungs to pick up oxygen. And then you're going to have your aorta, which takes that then brought back oxygenated blood from the lungs via the pulmonary veins. The aorta then takes the blood out to your body, so you have oxygen to your brain and your muscles and everything like that. So what happens is there's 2 phases of the cardiac cycle, basic ones that are very important, and it's known as systole and diastole. So both of these words are really referring to the ventricles, and so it's describing their filling or emptying. So systole means that you're going to hear a s, really a thump, because that's going to be when your ventricles are contracting and pushing out that sizzling blood out to your body or to your lungs. So when both of these ventricles contract, it's known as systole. So it's going to sizzle all that blood out to the lungs and the body. And then when this ventricle relaxes, then the atrium will contract and push blood into the ventricles to fill them. This is known as diastole. So that's those 2 are the main phases. So how this works is from your body, you use up oxygen, correct? And you collect that blood in your veins, and your veins then collect together, and eventually they come into one of these 2 main vessels, superior or inferior vena cava, which empty into your right atrium. So deoxygenated blood is described as the blue. Now, during diastole, right atrium contracts and pushes the blood into the right ventricle. So now this fills up. When the ventricle wants to contract, it does so, and when this happens, it closes this valve. This valve is known as your tricuspid valve for your right side of your heart. So tricuspid is your right. Because the blood pushes back and closes, it's a one-way valve. So when the right atrium contracts, it opens the valve, pushing the blood into the right ventricle. When the right ventricle contracts, it closes this valve, the tricuspid valve. But it also, because this is a one-way valve, pushes open the pulmonary valve, which is a semilunar valve. Is another way of describing it. And I'll be showing you those in just a little bit. So this blood kind of flows through this into the pulmonary artery and then branches out to the lungs to pick up oxygen. Once it picks up oxygen, it comes via the pulmonary veins. So remember, the term artery is a term of blood going away from the heart. Away from the heart. Blood coming back to the heart, no matter which way, doesn't matter if it's deoxygenated or oxygenated, blood coming to the heart is via veins. So don't get confused when it comes to the pulmonary system. When you push blood to your deoxygenated blood to your lungs, don't say, oh, it's deoxygenated blood, it's a vein. No, that's incorrect. It's actually arteries. But the blood coming back that is oxygenated is veins. So this is where it gets a little tricky. Definitely organize that and keep that in mind when you get to pulmonary physiology, your first term. And when you're doing cardio as well. So you get this blood back to your left atrium, now that it has oxygen. And again, same cycle. Both of these atrium contract and it opens up this valve. Now on the left side of the heart is known as your mitral or your bicuspid. So tricuspid on the right, bicuspid on the left. Or mitral is another way of wording that. This blood comes into your left ventricle. Now the left ventricle wants to contract during systole. Remember systole, sizzle? So we're going to contract and push this blood. It pushes against the valve closing it, the mitral valve, and pushes against this valve, which opens. And now the blood flows up through your aorta, goes up to your head and your arms, as well as your abdomen as this aorta descends down to your lower parts of your body. So the blood will go out. And then once it gets to the organs, it starts collecting back into the veins, and the cycle starts again. On average, you have about 5 liters of blood per minute flowing through this cardiac cycle, and it's known as your cardiac output. So when you get to physiology, now you know what that term means. So now a little bit importance. We did discuss this in our thorax video, so I'm going to do this very quickly. We have general visceral afferents. So these are visceral organ sensory fibers that pick up sensory from your heart. And there's something known as referred pain. When these nerve fibers synapse on the same nerve that your body wall nerve fibers synapse, is going to confuse your brain, and your brain's going to think you have pain from somewhere, but it doesn't know where from, either the body, like if you got poked in the chest or your arm, or from the heart. So it says it's from both. So that's why when you have a heart attack that has the pain and your brain doesn't know where it's from, it's also going to say, oh, you must be having pain from your body wall, your chest or your arm. So when people have heart attacks, that's why they have pain in their left chest and arm. Why is it on the left? Because your heart's on your left. So that's where most of these cardiopulmonary nerves, these guys right here, are holding on to your heart visceral afferents. So definitely get familiar with hearing those words, because you'll have that as a choice options from your anatomy questions as far as where these fibers are located. They can say, oh, the nerve that's attached to the heart that does sensory, what is it called? And you're going to need to know it's post-ganglionic, so it's after the synapse in the sympathetic chain ganglion right here. And you're going to need to know that it's a visceral, because it's an organ. And you're going to know, because it's sensory, it's going afferently or back to the spinal cord. So it's going to be a postsynaptic visceral afferent. It's that fiber, this one right here. Now, if it was talking about, oh, where are the fibers or the cell bodies for these ones, you need to know where those cell bodies are located, either in the ganglion, which is going to be this guy, postganglionic, or the cell bodies for the presynaptic are going to be in your dorsal root ganglion. So that's definitely important to remember all those, because and you'll get a ton of them in your Grace practice questions. So definitely pay attention to those and practice those quite a few, so you can get those free points pretty much on the exam. So now a little bit more as far as heart. We did talk about some of the effusions as far as the lungs and the thorax go. But now we're here with the heart. So we have a few procedures that go to help patients with this, but let's go ahead and describe this condition. So you have your heart and you have your pericardium, which is going to be kind of like the parietal pleura and visceral pleura of the lungs that we talked about, but this is more for your heart. So you have a visceral pericardium, which is going to be right around your heart, but then you have a cardium, and then you have a parietal cardium around as well. But in between this, you have pericardium. There's a space in between these, right? Peri. So when this fills, if this fills up with fluid, just basic fluid, either water or something like that, it happens often. This is known as a cardiac effusion. So effusion just means fluid. Now, in an effusion class, a more defined subclass can be a cardiac tamponade. So this is what this slide is really emphasizing. If this fluid is specifically blood, you have a cardiac tamponade. And what's a way you can determine if this patient has this? Well, there's three clinical symptoms known as Beck's triad when someone has a cardiac tamponade, so bleeding into their pericardium. They have decreased blood pressure. Why? Is because this fluid fills in a space that can't go anywhere, so it pushes in on the heart. If the heart gets pushed in, it can't fill with enough blood to push out enough to your system. Therefore, it has very little amounts of blood, and your blood pressure is going to be very low. Next is going to be muffled heart sound, because again, your heart can't beat strongly because it can't expand and fill up with a lot of blood. So when it does that, now the heart is going to be quite a bit more quiet, in addition to you have fluid in the way of when you're listening to your heart. Next is going to be increased venous return, otherwise known as jugular distension. So you're going to have your jugular veins up in your neck. You're going to be very distended and bulging out. That's kind of emphasizing that you have increased venous return, but that's not getting into your heart, and you can't push it out to your body. So that's going to be one of the problems there. Next, as far as how do we fix this? So this is going to be known as a pericardiocentesis. And how we assess to do this is we want to insert the needle in the 4th and 5th intercostal spaces right here and go at a 45-degree angle from the xiphoid. when we do this, it goes directly into this pericardium. You're going to hear a slight, or feel a slight pop through, and then you're going to be able to drain quite a bit of fluid out of there, or blood if it's a cardiac tamponade. And that's going to really relieve a lot of the patient's symptoms. But if it's blood, you're really going to need to try to figure out why there's blood in there so you can go in and surgically fix that. So next is a little bit about the heart. So we're going to go over to essentials anatomy in just a second, but I want to describe to you some of the basic heart structures and blood vessels. So this is very, very important, very high yield for not only lab, but also your lecture material exam. So trying to understand, okay, when I'm looking at a heart, how do I figure out which side is front, which side is back? So first you look at this point of the heart. That's going to be your apex. Next, you're going to see a bunch of vessels, big fat ones. If you see big fat open vessels, you're now looking at the front side of the heart. So that's really going to help you orient yourself. See these big giant vessels that come up. You're going to see your ventricles kind of bulging out here, a little atrium and a big left atrium over here, and then the point goes down and to the patient's left, or right in this picture. So you have what is known as your carotid or coronary arteries. My apologies, coronary arteries, and I'm sure you've heard coronary bypass or coronary artery stenosis or something like that. Those very clinical, significant conditions. Well, these are what it's referring to. These blood vessels fill in with blood during diastole. When the blood goes through here systole, and then when the valve closes, the semilunar valve in the aorta closes, then the blood can come backwards and flow into these vessels and supply the musculature of the heart, which is very, very important. If you have those plugged up, then you have ischemia and possible heart attack, myocardial infarction. So you have your right and left. And now there's two types of patients, right and left major patients, and we're going to discuss those in just a little bit, but let's describe the basic anatomy. So your right coronary artery gives off a little blood supply, this little tiny one right here, that goes up to supply your SA node and your AV node of your atrium. It also comes down to supply your marginal or small marginal branches of your arteries, which supplies your right ventricle. Then as it goes around the back, it's going to supply something we will describe in just a second. Now to your left coronary. The left coronary artery gives off what is known as your LAD, right? So your LAD is going to be your left branch of your coronary artery. This anterior interventricular is another way, or anterior descending. So left anterior descending artery, LAD. It's going to be this guy is going to supply the anterior portion of the ventricular septum and your left ventricle. Now this comes around and continues as your circumflex, or circles around the heart, branch of your coronary artery on the left. So remember, left does that. As far as venous, on your right side you have your small cardiac vein. So if you can remember that one, don't worry about these. Small cardiac vein with your right coronary artery. Great cardiac vein with your LAD. Great cardiac vein with your LAD. Now, the left circumflex comes around and supplies some of the blood vessels that supply the left ventricle. Very kind of insignificant. If there's a patient that is a left focused heart patient, then this actually will supply the posterior portion of the ventricular septum as well. But mostly, in almost all patients, you're going to have your right coronary artery that's circled around from the right side. So now we're looking at the posterior side. Right coronary artery comes around and supplies, this is the PDA, posterior descending artery. So PDA is right in coordination with the middle cardiac vein. And how I remember this is middle schoolers show PDA. So that's the vein that's associated with the artery here. So middle schoolers, middle cardiac vein, show public displays of affection, or PDA, posterior descending branch of the right coronary artery, also known as your posterior interventricular, which is more descriptive and very helpful in understanding where you're talking about. The coronary sinus collects all these venous inputs from your heart, draining all the veins from your heart, and goes right into your right atrium, which then can go and follow the cardiac cycle. So now, a little bit about a little more specifics. Definitely, this is a very helpful chart, so definitely get access to our files so you can check this guy out. It's going to help out just oriented which branch is accompanied by what vein and where is its supply. So now a little bit about pericardial sinuses. So pericardial sinuses are super, super basic. The only thing that they would really test you on is really this transverse pericardial sinus, because then they can ask you, if you're going in for surgery, what can you clamp via this? The oblique pericardial sinus is very boring. It doesn't do anything, and you can gain access to that via the back portion, which is right here. So the back portion of the left atrium. Now for the transverse sinus, you can slip in behind the superior vena cava and anterior to the aorta and pulmonary trunks. So if you want to stop the blood supply out to the body and the lungs, then you're going to be able to clamp these via the transverse pericardial sinus. All right, so here we are with essentials anatomy, and we're going to go very quickly through what I just kind of went over. This is a very helpful application to understand a lot of different structures, actually the entire body, and you can actually organize and set apart different organs and such like this. So here's our heart, and we can look at it in three-dimensional and zoom in and everything. It's very important to understand, again, those coronary arteries. So when we're looking at it like here, we see our big giant vessels, we see our ventricles and these vessels coming out of it. We see our nice little atrium over here. We might not see these blood supplies in lab and stuff like that, except maybe in images. And then we have our different, we can see our septum right here with a little bit of fat around it. And that really helps us orient that this is the front of the heart that we're looking at, and it's pointing down to the left, like normally. So a little bit as far as the blood supply. So we can see our pulmonary trunk here. I'm going to remove that. So you can see our aorta, ascending aorta here, correct? And our aortic bulb. So our aortic bulb has our coronary arteries that come off of it. The left coronary, which comes around and supplies and takes off the anterior interventricular branch, which we discussed, or LAD. And then we have our right coronary artery, which gives off blood supply that goes into the right atrium, as well as goes around in circles to the back side to supply the posterior interventricular branch, the coronary artery, also known as your PDA, because again, middle schoolers, middle cardiac vein, and your PDA. So middle schoolers show PDA. We have our coronary sinus, which drains right into our atrium, which I can show you this. So we have our coronary sinus. You can't really see that. But that drains right into our left atrium, or right atrium, to then feed back and go into the cardiac cycle. We then have our left atrium here and our left ventricle, which is this guy here. Why is it not clicking that? Whatever, this is the left ventricle. We can then open up and see the interior portion of the heart. So I was telling you that I was going to show you these valves. So as we look inside the heart, we can see a nice little thing right here. This is known as your mitral valve right here. So it's the left ventricle. Remember, we're looking at it from the anterior side of the heart. So this is actually the left. So the left ventricle, between the left atrium and the left ventricle, we have a valve, and it's known as your bicuspid or mitral valve. So as you can see, it has two cusps that are attached. And this is important for in processes of diastole, when the blood goes from the atrium into the ventricle. Now when the ventricle contracts and pushes it out, this mitral valve will close. And then it will open up this guy up here. This is the aortic valve, or semilunar valve, and that will go up into this aorta here. Now right ventricle, we discussed our tricuspid valve, which is right here. It comes from the right atrium to the right ventricle, and then the blood will then flow and close this valve when during systole, and push the blood out through the pulmonary, which will go up through the pulmonary trunk, this guy here, which I have removed. A couple other main structures. We have our anterior ventricular septum, which is here, and the posterior is on the back side. It kind of forms all this one big, very muscular septum. And then we have several regions. So we have a marginal band, which they're most likely going to label in your lab exam, so definitely keep track of that, and you'll learn that as well. It's just a band of musculature that comes out for the attachment of different portions of these fibers for the tricuspid valve. So that's the basics for the heart. Let's head back to the clinical. So now a little bit about fetal circulation. Fetal circulation is very important to understand, not only for anatomy but also physiology. It kind of helps you orient a little bit about how a baby develops and how it survives in the womb when it has no oxygen to breathe through its lungs. So when a baby's in the womb, the lungs are filled with fluid, amniotic fluid, correct? And when this occurs, that means we have a great amount of pressure pushing against these pulmonary arteries. Therefore, we're not actually going to get any blood out to the lungs. They kind of stop. So it needs to somehow go back into the circulation process. And how this happens is we have quite a few areas where connections are made only in fetal life, but not in adult life. So let's go ahead and start down here, and we'll come across all those as we go. So we have the placenta, which is attached to the mother, and that's where the blood kind of passes through and gets filtered and make sure that all the good stuff comes in and all the bad stuff goes out. As well as we need to get IgG, immunoglobulins, to help the infant supply some of its basic immunological function. So we have this blood that comes in, and it goes into the umbilicus of the baby, which is this guy right here, and it is now the umbilical vein. Remember, vein is something where blood is going back to the heart. So yes, as we're inside the baby, it's now a vein that's going to the heart. So now, since we have this blood coming back to the baby's heart, it's known as umbilical vein, and how it cuts across into the baby's main blood vasculature is via the ductus venosus. So ductus venosus is something that stays open when only you're an infant or fetal or a fetus. So the blood will come into your inferior vena cava. This is oxygenated blood from the mother coming into a venous system, which you're thinking, oh, this is weird. So this is oxygenated blood goes into the inferior vena cava and comes up into the right atrium. Now this is draining all the other parts of the baby's body, which has deoxygenated blood, that's blue. What happens is, in between your two atrium, you actually have this little septum, and this blood comes in fast enough that it pushes through to your left side of your heart. Why? Because if it tries to go on the right ventricle and goes up to the right pulmonary side, remember, these lungs are pushing back. So it actually increases the pressure here, leading to the blood really having no option to go except through from right atrium to left atrium. This is known as your foramen ovale. Now once it goes through this, or oval foramen, now once it comes through into the left atrium, it goes down into your left ventricle and gets pumped out your aorta, going to the system like your baby wants to have. But we do have a slight mixture of deoxygenated and oxygenated that gets into the right ventricle and comes up into this pulmonary trunk. Now it can't really go backwards because those are closed valves, right? We talked about that. It's one-way valves. So what happens is there's actually another connection, this is very important, known as your ductus arteriosus. We had ductus venosus down here. Ductus arteriosus is from artery system, blood going away from the heart. So this connects your pulmonary trunk to your aorta. So this has mixed blood going up and now is mixing with your oxygenated blood that kind of passed through into here. Once these come together, now you have mixed blood in your descending aorta that goes down to your body. You also then have some of this blood going out via the inferior epigastrix, or your umbilical arteries. I'm sorry, not inferior epigastrix, umbilical arteries that go back out to the mother. So this is the fetal circulation cycle that occurs. What happens is at birth, because you remove all the fluid from the lungs, now this pressure is decreased. So it decreases so much that this ductus arteriosus closes, and the blood can then flow into the lungs to pick up oxygen and come back to the heart properly. What happens then is the left atrium pressure is now greater than the right, and this will close the foramen valve. It's like a little valve thing that only opens one way. So when this occurs, this is what happens at birth, and you also get separated from the placenta, so this ductus venosus disappears as well. you now have a functioning adult. There's a video I'll be posting, absolutely amazing for the development of the heart for embryo. So definitely check that out. Highly, 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 highly recommend. It's from like 1950, and it's the most amazing thing ever. So definitely check that out. Now a little bit about kind of what that video goes into details with. I'm not going to go into extreme detail here. But you have this tube that makes your heart. So this is a little bit of embryology. So you have what different regions of this. You have your Truncus arteriosus, which is right here. You have your bulbus cordis, which is right here. You have your primordial ventricle and primordial atria, which are here and here. And then you have your right horn of your sinus venosus. So sinus venosus is going to make your venous structures that go to your right atrium. So what happens is this heart ends up folding in a correct way, that these structures, they're kind of malleable and like Play-Doh. They wrap around and hook to each other and stick together, and then they form all the chambers of the heart and separate and form septums and stuff in between them. And you'll definitely check out that video when I post it. But a little bit that goes into this is when you start forming that septum, remember the foramen ovale that goes from the right atrium to the left atrium, that's normal. However, sometimes some of these septum formation problems can arise, and one of the most important and common ones is going to be your ostium secundum. These are all known as atrial septum defects. You have different ones that arise in different conditions, but ostium secundum, atrial septal defect, is what happens when the oval fossa, or this region here, the second secundum, does not actually close all the way, so it remains too open. So that valve actually can't close over this. So even when the pressure changes, you now have a hole in between them. This is very common. I mean, more common than not. But this is really just due to a failure of that septum to fully form properly. Another one is going to be endocardial cushion. So there's these little cushion things that the septum kind of arise from. This is also comes up often in patients with trisomy 21 or Down syndrome. This is a problem that comes up in a lot of these patients. And really, you can't form the bottom portion of the septum and hook these together. And then you have your sinus venosus, which is really where your sinus venosus kind of wraps around and hooks up, and then hooks up the venous system to your atrium. If that doesn't happen and it remains open, then it's going to be a problem, because it leads to opening up more on the top part of your atrium, allowing blood to then shift from left to right. Not super problematic. Patients will not have cyanosis here, but it's still something that could be fixed. Here are some of the different types. Definitely check out our files to get this chart, or just pause the video and write them down. It's very helpful understanding why. Exact definition: primum type, often found in Down syndrome, ostium primum not closed. Also, the endocardial cushions also is a problem with Down syndrome. So now a little bit more as far as large problems that are found in the heart. One condition known as persistent truncus arteriosus is what happens is you're supposed to make a septum that divides the pulmonary trunk and the aorta, right? Because you want blood to go to your lungs only, or you want blood to your body only. You don't want the same blood from these two things going in the same direction, oxygenated, deoxygenated, or else you'll have deoxygenated blood going to the system, which will cause cyanosis, and that's very dangerous, especially when it gets up to the brain. So this is due to failure of neural crest migration to form that septum. And what happens is then the blood from your right and left ventricles contract and push up into both of these areas, and they mix together. This is very dangerous. Transposition of the great vessels is another important condition to understand. What happens here is the septum actually forms improperly. So what happens is instead of having your right ventricle hooked up to your pulmonary trunk, it's now hooked up to your aorta. So now your deoxygenated blood is pushing up into here. You also can have a ventricular septal defect. So So you have a little bit of blood coming from the left heart to the right, but then also your left ventricle is hooked up to your pulmonary trunks. So this is very dangerous because now you're pumping deoxygenated blood to the body and oxygenated blood to your lungs. So you're really counterintuitive of what you need to do. So this is cyanotic heart disease. You find this very quickly in patients right after they're born. What happens is a failure of the conus arteriosus to develop normally. The next is going to be Tetralogy of Fallot. So this is something, tetra means you have 4 things that come arise. These 4 are listed here: pulmonary stenosis, ventricular septal defect, overriding of the aorta, and right ventricle hypertrophy. So let's do a little bit of details, description of what on earth do those terms mean. So Tetralogy of Fallot is a problem that often arises in a lot of different cardiac anomalies, such as Down syndrome is one of them. That this is a possibility of occurring. Very little less likely than some of the other conditions. One other one is known as DeGeorge or Catch-22 syndrome. And also there has like 20 names for that condition. But that condition also can lead to cardiac anomalies here. So what happens is first you have pulmonary stenosis in addition to ventricular septal defect. So stenosis means just thinning or narrowing of a passageway. So your pulmonary artery here comes out and goes to your lungs, correct? And what happens is it gets very thin, so stenosis, very narrow. So now it's a very small thing. You have to try to increase a lot of the pressure in order to get the blood out through this now narrow hose, in a sense. So what happens is now you need to build more musculature. So now you build more musculature on your right side of your heart than normal. Your left heart is supposed to be more musculature than your right because it's usually pushing against air, which is air is very low pressure, so it shouldn't have a lot of muscle. However, when you start having this problem, you start developing musculature here. Again, we described that you have a ventricle septal defect, so a space here that allows blood from the left and right ventricles to kind of mix and pass together. But now, because it can't go out this pulmonary trunk, it starts building up a lot of pressure here on the right. You start building more muscle here on the right. Now it's strong enough that this blood can go from right to left. Now this is a problem because you have deoxygenated blood on this side going to an oxygenated area. Oxygenated area now is carrying blood wanting to go up to the system. So now you have deoxygenated blood getting pumped out the aorta. And this is the last important thing here is your overriding of your aorta, because now you have all this blood, extra blood, that's getting mixed, deoxygenated and oxygenated going to the system through your aorta. So you have extra blood through this. This is dangerous because it increases pressures greatly to a point that you can cause maybe a rupture in your aorta and you can die very quickly, lose all that blood very, very rapidly. And so that's going to be your Tetralogy of Fallot. Another condition is known as Dextrocardia or situs inversus. So Dextrocardia, specific for the heart, is when your heart actually folds in a different direction. So I'm going to draw something that's very simple. So you have your tube of the heart, all this stuff, Truncus arteriosus, all this stuff. So here's your tube. What happens is we have an arrow. Okay, so just imagine an arrow here. So this is a straight arrow as I can right now. So with this arrow, what happens is it bends. What happens is it bends to the right in order for the heart to go left. So normally. So it bends pointed to the right. So here's the point, it's pointing to the right, correct? So this is left, this is right. So it bends to the right, meaning the arrow or the direction of the heart is actually going left. So this is normal heart. And then it folds all up and comes back and it makes a little heart. That's my wonderful heart drawing right there. So it folds up directly like this. So here it bends to the right, meaning the heart's going to go left. So it comes and it folds and makes a little heart. See this little heart? Now, in dextrocardia, what happens is you have your little line, and now it bends. Whoops. I'm going to redo that guy. So now what happens is it now bends to the right, meaning the heart's going to go left. So here's the bend right here. That's bending to the right. correct? So now the heart goes left and then folds up. So now your heart is actually facing the wrong side, or the right. So here we are. Usual cardiac shadow is going to come around here for your left atrium, and then you're going to have a shape that looks just like this. That's what your normal heart looks like. However, in Dextrocardia, you can see from this shape is pointing to the right side. Now, if it's full situs invertus, means all your internal organs and your heart and everything are switched to the opposite side, which there's some famous people such as Enrique Iglesias has this. Actually, all your internal organs will shift to the other side. How do we know this? See these little air bubbles below your diaphragm? That's your stomach. Is your stomach on your left side or your right side normally? Well, answer to that is it's usually on your left, but on this patient it's on the right. So this means that their whole internal organs, everything have switched to the opposite side. And here's your liver, nice and smooth, no air bubbles. So now cardiac shunts. This is very important to understand. So there's actually a way to remember these if you orient them. So you have your left or right shunt. It's not going to cause cyanosis because you're not getting deoxygenated blood to your system. That's something like atrial septal defects, ventricular septal defects, patent ductus arteriosus, remember ductus arteriosus, and then atrioventricular defects. Now, right to left, these are important. These are very important. If you can remember this, you have 4 of them. Actually, you have 5 of them, but 4 of them as far as anatomy purposes go. They all start with T. Okay, so they all start with T. And it's important because if you orient them in numbers 1, 2, 3, and 4, then it kind of goes along with this. So just imagine you have one tree, and it has one trunk. So in one trunk, if you have persistent truncus arteriosus, meaning you have your aorta and your pulmonary trunks never divided, and it's just one giant trunk, that's going to lead to right to left shunt. Now you have T, another T. So now you have transposition. So now your aorta is attached to your right ventricle and your left ventricle is attached to your pulmonary trunks. So they switched. So now you have transposition of the two great vessels. So one trunk, 2 great vessels, or great arteries. 3, oh, what do you know? Tricuspid atresia. What the heck is atresia? So if you just think of this, you have a big giant sink and it has a plug at the bottom. You're like, oh, I don't have a plug to plug up the water. Maybe I want to take a bath in this giant sink. Oh, well, let me go cut down a tree and shove a tree into this and plug it up. So that's exactly what atresia is you have plugged. So the tricuspid valve never opened. It's just a plug. So now the blood goes from your right atrium to your left atrium by the foramen ovale. When this happens, you have cyanosis that can occur. Next is going to be 4. And what's the 4 root? Oh, that's right, tetra. So Tetralogy of Fallot is going to be your 4th. So we discussed that a little bit earlier, and that's going to be your remaining right to left shunt. I hope this helps. That's all that we have for today. And if you have any questions, definitely post on our Facebook page. If you want access to these files, join our Facebook page. And that's going to allow you access to look at these and be able to study from this. Hope you enjoyed. Don't forget to subscribe and check out our other videos.